Jeff Askey and Charles Horn. Jeff is a manager in Draffin and Tucker's Reimbursement Service Group. His public accounting career has been concentrated in the healthcare industry with extensive experience in auditing, preparation of program reimbursement reporting forms, provider enrollment, and healthcare consulting engagements. Jeff has successfully completed the American Health Information Management Association Independent Study course for medical record coding and is certified as a certified coding assistant. Since obtaining this certification, he has been involved in numerous consulting engagements focusing on medical record coding from both a reimbursement and compliance aspect. Jeff has also been an educational presenter at various industry settings discussing the increasing focus and importance of coding to the healthcare industry. He is a certified public accountant licensed to practice in the state of Georgia. Charles is a partner in Draffin and Tucker's Audit and Accounting Service Group, where he concentrates on the healthcare industry. He has extensive experience in auditing, preparation of Medicare, Medicaid, and Blue Cross reimbursement reporting forms, tax return forms, and provider representation in dealing with state and fiscal intermediaries. Charles is directly involved in the full range of accounting services provided to hospitals, nursing homes, and other healthcare facilities. Charles is a certified public accountant licensed to practice in Georgia and Alabama. Now, I'll turn it over to Jeff and Charles.
Well, good afternoon, or again, good morning, depending on where you are located here today. We want to welcome you to the second part of our webinar series, Understanding of the S-10 Worksheet. We went over part one yesterday, which was basically an overview of what the worksheet and what CMS required you to report on it related to uncompensated care that your facilities may be rendering to patients. The second part of the webinar today will be looking more of an overall understanding of how the S-10 is currently being used, where we believe CMS will be taking it as far as its future uses, and we'll be giving not only information related to the form itself, but also some commentary of, again, how we are interpreting where we believe CMS will be taking and using this information in future periods. As before we start, I guess, today, I just wanted to let you know that as we go through today's presentations, if you have any comments or questions, if you'd like to type them into the chat box area on your computer, we may take the time to pause and address those comments or questions that you have as we're going through. We will have a question and answer session at the end of today's webinar, just like we did yesterday. But again, if you are so led to post a question or a comment during the slide presentation, we may take the time again to address it as we go through.
And as it relates to that, this is Charles. It's great to be here. It's an honor to be here with y'all today. We hope that it's going to be a significant amount of good information for you to use going forward. But as it relates to the questions, if there were any questions that you have subsequent to yesterday's session that you want to get started with today, please don't hesitate to go ahead and type those questions in, and we'll attempt to get those addressed as well.
Again, our disclaimer page, as this is sort of a ever morphing type document within the hospital cost report, to the best of our knowledge, the information that we are providing you today is true and accurate and complete. Again, as is subject to change, we just ask that you keep this in mind, and if there are any questions related to your S-10 worksheet and the data that's required to be reported within it, ultimately it's going to be CMS's determination if you are completing the form accurately, and we would suggest that you follow up either with your cost report preparers or your individual MACs if you have any subsequent questions.
And certainly to address your hospital-specific situation.
Again, I'd like to point out the resource, which I think was included with your email notification when you registered with this webinar, that the National Rural Health Resource Center, with the assistance of our office, has put together a Worksheet S-10 guide that you can reference for future purposes to help you in completing the S-10 worksheet when you go to file your cost reports. It can also be found on the National Rural Health Resource Center's website at ruralcenter.org under the featured resource section, or you can look through their search engine for S-10 and pull it up in that manner. So again, just sort of a rehashing of what we started with yesterday. What is the Worksheet S-10? Again, it's the form that Medicare CMS has decided to gather uncompensated care data, cost information. It's required by hospitals to complete, both PPS providers and critical access hospitals. And again, capturing the uncompensated care cost for your facility. Again, this is probably the single largest depository of this type of information. I mentioned yesterday that, to my knowledge, it's one of the few national standard forms that gathers or tries to gather this information. You do have other examples of uncompensated cost information that's being reported possibly either through tax-exempt hospitals filing their IRS Form 990 in the Schedule H, which tries to gather community benefit information. You also have individual state DISH surveys that may be gathering similar type information, but again, this is probably CMS's attempt here through the hospital cost report, Worksheet S-10, is probably the single largest depository of this type information. Again, just an overview of the type of costs that CMS is requiring you to include in the S-10 worksheet itself. I mentioned I sort of like to break it up into three separate sections. The first section is related to unreimbursed program cost related to the Medicaid program, the state children's health insurance program, and any other state or local government indigent care programs. That again encompasses your unreimbursed cost. And then what Medicare refers to as uncompensated care cost would be then your charity care and your bad debts.
And just to revisit the definition or what comprises bad debts in relation to the preparation of this form, it's primarily your uninsured population, services provided to your uninsured population, as well as patient responsibility amounts, deductibles and co-insurance that were ultimately not paid for those that did have insurance coverage.
So how is the Worksheet S-10 being used today? Well, again, we mentioned yesterday that it does have some impact on your Medicare and Medicaid electronic health record, EHR incentive payments in the determination of how much your facility receives. I think we mentioned yesterday that those will be phasing out fairly soon if they haven't close to already. CMS is planning to use the S-10 data to allocate your Medicare DISH uncompensated care payment pool in the near future. And again, we're not exactly sure when the near future is going to be, but it is basically CMS's intention to move towards using the S-10 data fairly soon. And then we also mentioned that there are certain groups that may be looking at your S-10 data. Some have lobbied Congress looking at the 340B drug participation program and determining whether facilities should be eligible to continue participating in that. We've got other groups that may be looking at tax-exempt status of providers, and they're using this data to evaluate whether or not they feel like hospitals should maintain that status. So again, as I maybe have mentioned yesterday, we're not exactly sure who all is going to be looking at this data, but again, it's probably one of the largest depository of this type of information in a national standardized practice. So this information will be utilized in the future for probably a plethora of reasons.
And really, one of the reasons we're created the guide or assisted in the creation of the guide and are conducting these 2 webinars is to drive home the necessity for accurate reporting on this form. Every known and projected purpose should lead you to the conclusion that this needs to be as accurate as possible in your particular situation. Some of the bad data could ultimately result in incorrect interpretations and damaging conclusions by others that may access this information in the development of their plans or goals.
So again, I mentioned the EHR incentive payments. If you're not familiar with those, the EHR incentive payments was a mechanism that Medicare and Medicaid has put in place to help financially offset the health care systems being moved to using electronic health records. And this is to help offset the cost of adopting, implementing, upgrading, and demonstrating that you are a meaningful user of that type of technology. The EHR incentive payments, again, are sort of being phased out for critical access hospitals. They were eligible to receive these payments through federal fiscal year 2015, and hospitals paid under the inpatient PPS system can receive these additional incentive payments through federal fiscal year 2016.
Which, 15 is going to be wrapping up here at the end of this month, and federal fiscal year 16 will start 10/1. So the prospective payment system hospitals, this is their last opportunity, if they haven't yet, to participate in any of that incentive funding. And then shortly thereafter, if you're not in compliance, as you all probably well know, there'll be potential penalties associated with that non-compliance.
So how is the S-10 data then being used to impact your EHR incentive payments? We mentioned yesterday when Medicare is determining your amount of incentive payments you qualify for, is taking charity care charges that you are reporting off the Worksheet S-10 on line 20, column 3, and they are using that to determine your Medicare fraction, which we'll get to in the next slide, an example of how that's being impacted. Generally, the higher the incentive payments that you are available to receive, it's in proportion to the amount of charity care that you are reporting on this S-10 worksheet. So increasing your charity care charges will increase potentially the amount of EHR incentive payments that you will be eligible for. Again, the base amount can be adjusted for the PPS providers, and reasonable costs are paid for the critical access hospital population. Now here's an example of how the charity care that's being currently reported could impact your EHR incentive payments. If you look at the 2 columns here, calculation 1 and calculation 2, we're trying to show you the difference in, say, one facility who had $100 million in charges. 10 million of that was charity related in the first calculation. What Medicare does in computing your EHR incentive payment, or how much you may qualify for, they reduce your total charges by that charity charge amount. So in calculation 1, we went from $100 million to a net charge amount of $90 million if we reduce it for the charity care. They then look at your total days that you you've reported on your cost report, and they multiply it by that net percentage of total charges, the net charge after the charity care has been removed. In calculation 1, you can see our net charge amount is 90% of what we started with, of gross charges of $100 million. They multiply that 90% by the 10,000 days and give you an equivalent days, excluding charity, if you will, of 9,000 days. Well, when they compute your Medicare percentage, then they're going to take your Medicare days, in this case 5,000, and divide it by your adjusted patient days that exclude the charity component, which is 9,000, and come up with a Medicare percentage of a little over 55.5%. For Medicare purposes, your EHR incentive payment, you get a base amount, which is $2 million, plus an additional amount for each discharge over a certain level, which we are not accounting for in this example. But if you take your Medicare percentage that we've computed times the base amount in calculation 1, for a first-year qualifier, you would have received an incentive payment of $1,111,111. Now, if we take that same hospital in calculation 2 and show that they had twice as much in charity care charges, $20 million versus the $10 million in calculation 1, you can see if you go through the calculation how the EHR incentive payment would grow to $1.25 million, which is $889 increase rather. So the more charity care charges that are reported on S-10, the higher potentially the incentive payment your facility could get.
And we want to clarify the note at the bottom where it states EHR incentive payment is prior to 2% sequestration reduction. That's only as it relates to the calculation example we've included here. We didn't want anybody to misinterpret that to read as if the sequestration didn't apply to Medicare electronic health record incentive payments, because it does. The ultimate amount computed here would be reduced by 2% to take that into consideration.
The next thing that is impacted or potentially going to be impacted by the S-10 data is uncompensated care payments. And as we probably well know, back in 2014 with Medicare's inpatient PPS final regulations, they implemented a change based on the Affordable Care Act that basically changed the way that Medicare distributes disproportionate share hospital payments to providers. Now, this payment was implemented to align DSH payments to the amount of uncompensated care hospitals provide. Yet that was their intention, but ironically, instead of using the S-10 data to start allocating these payments, they decided that they needed to hold off and continue with basically the old or empirical methodology for some time. Now, prior to October 1st, 2013, the beginning of federal fiscal year 14, hospitals would qualify for DSH payments based on a formula that considers Medicare utilization of beneficiaries who also receive supplemental security income benefits. That would be your SSI percentage, and also Medicaid eligible inpatient utilization or Medicaid eligible days. And again, this is referred to as the empirical DSH methodology.
And as Jeff mentioned, both of these bulleted items here as it relates to qualification are based on days information. What we really want to point out here is that going forward, even after the transition to the institution of the uncompensated care payment portion of your Medicare disproportionate share hospital funding, this still remains the trigger for payment eligibility. You have to meet the criteria as established under the empirical or old methodology in order to be able to participate in the 25% of the old and the new uncompensated care payment component.
So again, with Medicare's change effective with the 2014 federal fiscal year, basically your Medicare dish payments have been broken up into two separate components. The empirical payment, which is basically 25% of the old payment methodology, plus an allocation from a new Medicare dish uncompensated care pool.
And under the presumption that most of the audience today is smaller rural facilities, we thought it'd be important to note or mention that, or comment on, if y'all are familiar with the old empirical qualifying criteria, you would have to have greater than 15% qualifying Medicare DSH percentage in order to receive a payment. And for those of you that are smaller and rural, the great majority of you are probably capped at 12%, and your Medicare DSH qualifying percentage would have had to have been 27.6% or greater to meet that 12% payment cap. And, one of the questions I've always had is, what's the logic for capping rural providers at 12% when their actual qualifying DSH percentage may be significantly higher than the 27.6 that it takes to get you to the cap? Because what's happened historically and what continues to happen as it relates to the 25% component of the DSH payments is that, you're not recognizing any payment benefit in the formula for your DSH qualifying percentage greater than 27.6%, where some of your urban counterparts and some of your hospitals that have certain Medicare classifications are not subjected to that cap and may be achieving higher payments with a lesser amount of Medicaid and SSI services being provided.
Yeah, and just to sort of piggyback, I think, on what Charles was saying, one good thing that has come regarding this change is since the empirical dish methodology is really being only applied to 25% of Medicare dish payments, you are still being capped potentially for that quarter or 25%. But with the new Medicare dish uncompensated care pool, any and all days that you report are going to be used to compute your allocation percentage. So in essence, the 75%, if you want to think about it, may no longer be capped like you are currently with the empirical dish only.
I know in our experience, in our hospital practice and the ones we work with, we have seen, especially in the first year, federal fiscal year 14, an increase in Medicare DSH and uncompensated care payments for those rural hospitals that had previously been capped at 12%, and still somewhat of an increase in the second year, but it's declining, and we'll cover some of that information in just a minute.
Okay, as far as the uncompensated care pool goes, what Medicare has tried to do is generate an amount that is equal to 75% of what they would have otherwise paid out to providers if they had not implemented this change. Basically, again, using the empirical dish methodology. And then they are reducing that pool amount, that 75% amount they come up with a reduction factor that is reflective of the change in the percentage of individuals under the age of 65 who are now getting insurance coverage under the health care reform system. Each hospital that qualified for an empirical justified Medicare dish payment will receive an allocation then from the uncompensated care pool based on its share of, again, total amount of uncompensated care for all Medicare dish hospitals. And again, using currently your Medicaid and your Medicare SSI days as the allocation measure, if you to come up with your allocation percentage. Just to throw out some numbers here related to the uncompensated care pool. Again, with federal fiscal year 2014 being the first year that we've implemented this split Medicare DSH payment system, if you will. In 2014, the actual pool amount that was distributed to providers was slightly over $9 billion. In 2015, it dropped, again, based on the increase in the uninsured under the age of 65 that became insured from the previous year. The allocation pool dropped to $7.648 billion. In federal fiscal year 2016, the same uncompensated care pool amount was reduced to just over $6.4 billion. Now, what is sort of interesting here is if you go back and look at the gross uncompensated care pool amount prior to the reduction for the drop in uninsured, for each of these 3 years, the gross pool amount was roughly $10 billion. So if you think about it, over this 3-year period now, which 3 years including federal fiscal year 2016, which we're about to get to, you have seen basically an overall reduction from what the empirical DSH methodology would have paid out of about $6.5 billion that's been removed from the Medicare payment system. I think as we go along over time, hopefully the reduced uncompensated care pool amount will sort of level out and we won't see a continued decrease year after year like we have been seeing.
Definitely, well, hopefully not in the same magnitude.
All right, this next slide just shows you sort of in a graphical format some of those same numbers that we just talked about. Again, I would anticipate that as we go further out in time, you'll see a sort of plateauing effect where the uncompensated care pool amount that is distributed will sort of level out and we won't see these deep reductions that we've been seeing these last couple of years.
And based on the Congressional Budget Office estimates, back in 2013, the percentage of uninsured under 65 was at 18%, and now they're projecting in the federal fiscal year 2016 final rule a decrease to 11%. And you can obviously see by the graphic that the reduction in the available monies for allocation have tracked that percentage decline.
Now, one issue that I think the provider community has sort of taken exception with is when Medicare wrote the new regulation related to the uncompensated care pool, they basically said that they would be using CBO estimates of the percentage of uninsured patients in reducing the gross uncompensated care pool. And their estimates are not subject to any kind of administrative or judicial review. So providers are somewhat limited in even trying to appeal that these reductions may not be appropriate or are excessive. In fact, HFMA recently released an article that basically said that for the 2014 fiscal year, the CBO had estimated about 14 million individuals becoming insured that formerly were uninsured, and their sources indicate that it was really around 8.8 million individuals that became insured that formerly were uninsured. So quite a difference in the estimates there that were being used.
And that doesn't even address the quality of the insurance coverage that is available or that these individuals have acquired as it relates to being uninsured or it basically being catastrophic coverage and really what that means to the hospital providers as it relates to attempting to collect.
Okay, I mentioned when they initiated the change that they wanted to, again, compensate providers for uncompensated care. They wanted to use the S-10 data to determine the allocation percentages, but because of concerns they had over inaccurate and inconsistent data, currently we have continued using the empirical dish methodology. Again, removing the cap for some, but continuing the empirical dish methodology to currently allocate uncompensated care payments to providers. CMS will be using, again, that SSI and Medicaid days until the S-10 data is felt to be reliable enough to start using.
And what they're using does appear to be or result in a more logical distribution or redistribution of the money available. Unfortunately, it's just being applied to a reduced amount, and it's happening now. I guess now is better than never, but it would have been nice if it would have been happening long before now.
Okay, so CMS has indicated back in the 2014 inpatient PPS rule that they intend to use the uncompensated care cost amount off of S-10, which is taking your charity care off of line 23, plus your bad debt expense, net of the Medicare reimbursement from line 29, and using that as the allocation measure to distribute the uncompensated care pool. So that would be line 30 of the S-10 worksheet that combines both your charity care and then the bad debt expense. One thing that CMS initially said that when they decided to change the methodology, one reason why they said they didn't want to use the S-10 worksheet just yet was because of potential Medicaid shortfalls that would be in the S-10 worksheet. They didn't want to discourage states from deciding on expanding their Medicaid programs if they were to use the Medicaid shortfall amounts off the S-10 worksheet. I think at this point in time, most states, based on fiscal decisions, have determined whether or not they want to expand their Medicaid programs. So I think this concern is probably somewhat in the past. And by the time CMS gets around to using the S-10 data, I don't think this will really be an issue anymore. Again, going back to the last slide, it looks like that their initial determination was to possibly just use the charity care and bad debt expense amount and not even consider the Medicaid shortfalls at all. But that is a possibility that they may want to include that.
And Jeff and I were talking earlier in preparation for today's webinar, and it really, I'm not so sure how much of a disincentive it would be in regards to making that decision, because it sure would seem like $1 of additional Medicaid reimbursement would still be greater than whatever percentage add-on would result in Medicare reimbursement.
So how would Medicaid expansion impact the allocation of the uncompensated care pool? Well, again, Medicaid days are being used currently to do the allocation. They're being used instead of or in lieu of charity care and bad debts for that matter. All right, under the current allocation method, though, states that expand their Medicaid program will probably receive higher uncompensated care payment distribution in future periods because they're going to have additional Medicaid days than they would have not otherwise had. Presuming no change then to the current allocation method, it would appear like states that have expanded their Medicaid programs will continue to see possibly a growth in their uncompensated care payment distribution, maybe disproportionately so, looking at provider states that have not expanded their Medicaid program.
And that's important to reiterate, or it's important to reiterate that this is under the current allocation methodology.
Okay.
Jeff, Charles?
Yes.
Aaron Beeswick has a question. Can the line 29 bad debt expense include insured bad debt?
Yeah. Basically, any bad debt that you're reporting on the S-10 worksheet is going to be related to any patient responsibility. So even if you have a third-party insurer payment associated with the account, if you have some amounts, coinsurance deductibles related to those patients that are not collected, and they meet basically, as I mentioned yesterday, the Medicare definition of a bad debt, where you've attempted to collect, applied appropriate collection measures on those accounts, then yes, those amounts can be captured. So again, if thinking back on yesterday related to the bad debts, you would report total bad debt expense for your facility on line 26, and then whatever Medicare bad debts that you claim that are reimbursed through the Medicare program, that will flow over from your settlement worksheets onto line 27 and reduce your gross amount. So again, bad debts related to the patient responsibility can be claimed.
Thank you.
Okay, so sort of continuing on with our Medicaid expansion impact, again, in theory, if your state has expanded your Medicaid coverage, then in theory, those patients who have obtained coverage through the expanded Medicaid program will probably be coming out of what was previously identified as charity care. So it would reduce your charity care costs potentially then, because again, they have now received coverage through your Medicaid program. When CMS modifies the allocation method, though, states that don't expand their Medicaid program will likely receive higher uncompensated care pool allocations. And again, if using their initial methodology of just looking at charity care and bad debts, if you move patients out of your potential charity care pool and now consider them as Medicaid, if Medicare uses only charity care and bad debt to do the future uncompensated care pool allocation, then those that have not expanded Medicaid coverage will likely see an increase proportionally of these type payments.
Jeff and Charles, we have another question. Are you expecting that high deductibles due to ACA will impact uncompensated care for those patients that can't cover deductibles and still receive care? Is that considered charity care? What do we need to be aware of regarding high deductibles and its impact on uncompensated care, if any?
Well, again, the high deductible issue is a growing issue. It is going to impact the distribution of the uncompensated care pool. Again, if Medicare decides just to look at charity care and bad debt expense, then based on whether these patient accounts qualify under your financial assistance policies, as charity care, they potentially would end up there. If you expect some payment from them, from their high deductible, and you do not collect on those, they would then probably become a bad debt, so they would be shown in your bad debt area. So they will be included in the calculation more than likely, just depends on where as either charity or bad debt. But yes, those will show up.
Yeah, I mean, I think the short answers to those questions are yes. Are you expecting that high deductibles due to ACA will impact uncompensated care? I do. For those patients that can't cover deductibles and still receive care, is that considered charity care? Well, that's going to be dependent on the hospital's policy as it relates to qualifying and categorizing people or individuals as charity care. What do we need to be aware of regarding high deductibles and its impact on uncompensated care, if any? That goes all the way back to business office practices and front-end collections and what have you, but it is a significant concern.
Great, thank you.
All right, are we ready for CMS to use the S-10 data to allocate the uncompensated care pool? We went back and looked. We looked at the 2016 DISH supplemental file that Medicare had put out, showing how much providers were going to receive out of this uncompensated care pool distribution for federal fiscal year 2016. There was a little over 2,400 hospitals that they showed were going to be receiving the uncompensated care payments. 43 of these hospitals reported negative uncompensated care on their S-10 line 30. Again, that's summarizing the charity care and bad debt amounts off the S-10 worksheets. And when we looked at those 43 hospitals individually, we determined that for the most part there was input errors for those particular cost reports. In particular, we saw like charity care payments were input on line 22, but they had no charity care charges that were input on line 20. Or they did not have total bad debts keyed in on line 26, yet they had Medicare reimbursable bad debts coming over from the settlement worksheets to line 27, and thus created a negative amount on those particular S-10s. So literally, if I were to say, are we ready to use the S-10? Well, based on these 43 hospitals, then I would say probably not.
And that's really one reason that I believe CMS had concerns in trying to get this changeover or this allocation change made to the S-10 data. Another thing that's important to point out is that sometimes, we've reviewed reports before, and there's some items, obviously, on the Medicare cost report. They're going to have more significant impact in the short term as it relates to your cash flow and the Medicare cost report settlement that is associated with filing that report for a specific period. And what we found is in some instances, some of these worksheets that people may not be paying that much attention to because they don't directly impact the short-term cash flow position of the facility. But unfortunately, if they're not tended to properly, they can have damaging impacts on future reimbursement. A couple of areas we're familiar with, wage index reviews, especially as it relates to smaller rural prospective payment system hospital facilities that may not believe they have as much and may not have as much of an impact on their rural wage index category. I think we can start to begin to lump Worksheet S-10 into that category as well, with the point being the focus needs to be on the front end and not after it's too late.
And again, as I mentioned yesterday, the one thing with the S-10 worksheet that we're still a little uncertain of is, what is the ability of providers moving forward to possibly amend or revise their data? Will there be a mechanism in place similar to the wage index data where that is reviewed on an annual basis prior to it being finalized? So we just don't know in that regard yet. So it's important to accurately report this information on the front end, so again, you don't have to deal with any negative consequences on the back end. All right, just another example, we had another 55 hospitals that reported zero uncompensated care cost on line 30. So 55 hospitals did not report any charity care or bad debt expense, and this would include Medicare bad debts for that matter. So again, just a small number of these hospitals that were included in the 2012 cost reporting period had obvious issues related to their S-10 data that needed to be addressed. Okay, so moving forward then, we did some of our own modeling, if you will, looking at comparative data related to the 2016 uncompensated care pool calculations and allocation amounts using the same cost report data that was being utilized for the allocation measure. Again, they were pulling Medicare days and SSI days. And we said if we went back and pulled S-10 data for these particular cost reports, what would the allocation look like if, based on, again, CMS's indication to want to use charity care and bad debts as the allocation measure, what would it look like for providers? So we pulled this information and applied our own percentages that we came up with using the uncompensated care cost just to see, how much of a difference would it mean to the allocation of the uncompensated care pool. So again, our information that's on the next few slides is related to using charity and bad debt off the S-10 worksheets to do our allocation versus using the Medicaid days and the SSI percentages of individual providers. What we found, though, is there is a tremendous amount of variability between each hospital's change in reimbursement. We sort of categorized them in buckets, as you'll see in just a second. So we saw maybe some trends, but even within each segment that we looked at, you could have, again, some winners and losers, because all we're talking about really is doing a redistribution of that uncompensated care pool. So it's really a relative measure of how your facility correlates to other facilities. So even amongst the buckets we're looking at, there could be winners and losers within that. So it's somewhat hard until you get down to the individual hospital level to truly know how the change to using the S-10 data is going to impact your facility. So this first slide we've come to is sort of breaking facility sizes down using beds, the number of beds you have, and determining how much of a change in the gross uncompensated care pool these providers would have gotten. So I'll sort of let this stay up here for a second just so you can look at the numbers, maybe gauge which bucket you might fall in or your facility would be falling in. Just sort of as an overall comment, do I think what Charles and I can gather from this is, again, if we're moving to looking at charity care and bad debt expense as a way of allocating the uncompensated care pool, it looks like the smaller hospitals, those that particularly are under 200 beds, may see an increase in the amount of uncompensated care payments they'll receive in totality, probably because of the patient demographics that they are serving more so than anything.
And just for clarity's sake, the amounts parenthetically are reductions. For example, the 201 to 300 bed category comprised 385 hospitals, and the result from our comparison would be a $108 million reduction in the uncompensated care pool for that grouping.
And again, just as sort of a rule of thumb, I think if you were to look at it from the standpoint, if you were a provider currently with a high number of Medicaid days and SSI days for that matter, in a relatively low uncompensated care cost amount, again, your charity care and bad debt expense, you're probably going to see a decrease if they switch to using the S-10 data. Conversely, if you're a provider with relatively low Medicaid days in SSI days and a high uncompensated care cost component, you're probably going to see an increase to your facility once they switch to the S-10 data. Okay, our next comparison just shows sort of breaking it down by regional division, what we're seeing using our same measures, using charity care and bad debts. And you could see it's somewhat I guess, all over the board as far as winners and losers. Again, this is by division group or regional sections, but this doesn't mean that there are not winners and losers within each one. So I'll leave that up just for a second so you can see. And again, I think basically patient demographics are going to be the largest driving force within these regions as to who might see some advantage, if you will, of switching to the S-10 data. Okay, moving on then, some assumptions that we made using 2014 comparative data, using 2014 cost report information. We again went in and pulled some cost report data looking at the uncompensated care costs off of line 30. That's the charity care and bad debt expense. We also looked at possibly the costs that are being reported on line 31, which consider not only charity care and bad debt expense, but the unreimbursed costs related to your Medicaid, your state children's health insurance program, and any other injury care programs that are reported at the beginning of the S-10 worksheet. We wanted to look at those costs in relation to then the worksheet A expense, your total operating expenses of your facility, just to see which areas or which hospitals might see a potential benefit using line 30 versus line 31.
And also as a sort of benchmarking tool as it relates to what your specific percentages are looking like in your situation in comparison to what the results are aggregated by census region that we're about to look at.
So you can see here with the first slide, we list the census division, the number of hospitals that were incorporated in the cost report information that we pulled. In the third and the fourth column where the percentages are, we show in the first percentage column using line 30, what is the percentage of charity and bad debt expense as a percentage of your total operating expenses off of worksheet A. The second column then, the percentages shows what that percentage would look like if we included your unreimbursed program cost in addition to charity expense and bad debt expense. So like Charles was mentioning, this may be a good measuring tool that you could use to look at to see how your facility compares, again, within your region and nationally for that matter. But these are some percentages that fell out with our comparison data.
And, to give you an idea of across the country what the relationships look like, where they appear to be higher in the South Atlantic area, as well as West South Central, and really what are the underlying reasons that occurs, and there could be several.
And this particular slide shows both PPS providers and critical access hospital providers. We went ahead and broke it down then and said, okay, this slide represents just the PPS hospitals. And again, what those same percentages would look like. The first percentage being just charity and bad debt expense as a percentage of total operating expenses, and then charity, bad debt, and unreimbursed program cost as a percentage of your operating expenses off of worksheet A. And as a footnote on this slide, you can see that even in the 2014 data, there were 73 PPS hospitals that did not complete an S-10 worksheet.
And that again reinforces the need for the accuracy of the completion of this worksheet as well as your entire report, because we're obviously aggregating information along the same lines that some of these other external parties might be. And, our results are only as good as the data that's there to be evaluated.
Okay, this next slide is just showing critical access hospitals. And again, you can use this as maybe a benchmark measure to evaluate your facility to see, relatively speaking, where you would land. Again, there's 15 critical access hospitals in the database that did not complete their S-10 worksheet. So sort of in conclusion, before we have our question and answer session, again, our focus of this entire webinar presentation has been to try to educate you on the impending use of the S-10 worksheet. In particular, its use in the allocation of the uncompensated care payments. However, you can see that the S-10 worksheet could be used by CMS and others for purposes even outside of the uncompensated care pool allocation. Again, we mentioned 340B qualifying criteria, examinations, tax-exempt status reviews. Again, we don't know who and how this information is going to be used, so every attempt to make it as accurate as possible is important.
One thing I wanted to point out is that, like the Worksheet S-10 results, like the state disproportionate share hospital surveys, like Schedule H for those of y'all that have 501c3 status and file an IRS Form 990, I believe the worksheet, an accurately prepared Worksheet S-10, can arm hospital boards of directors, hospital management with information that they're able to share with the local leaders, state leaders, as it relates to the volume and amount of estimated uncompensated care costs that the providers are basically subsidizing for the individuals that they serve.
And again, just to sort of conclude here with our final points is you should carefully review the S-10 data prior to filing to ensure it's as accurate and as complete as possible. As I stressed yesterday, maintain the support of the input items and amounts that are going into this S-10 worksheet and comply with cost-reported instructions. This information needs to be able to hold up under audit. Again, I would stress that you maintain detailed documentation once you go to file the report, and don't rely upon just summary information where you might have to go back later and try to recreate the detail. Again, what we've mentioned, even with the disclaimer, that CMS does intend on reviewing their instructions related to this S-10 worksheet to determine if any revisions or clarifications are necessary. Again, the provider community has expressed some concerns and interest that they do revise the instructions. So please try to keep up with any information that's being put out by CMS, in particular related to revisions or clarifications to these instructions.
And there have been some minor revisions or clarifications, but there hasn't been a wholesale change up to this point that we're aware of. And it's obviously been a while since it was first stated that they were going to be reevaluating the substance of the instructions.
So, Kim, with that, I think we'll open it up for questions or comments at this time.
Great, thank you. Does anyone have any questions? Star 2 to unmute your line, or feel free to type them in the chat box. Jeff, Charles, why is CMS using all components from the hospital cost report, the hospital sub-provider, skilled nursing facilities, etc., in the cost-to-charge ratio that is applying to charges when trying to determine how to allocate Medicare hospital uncompensated care payments?
Okay, yeah, I think there the question is why is CMS using a cost-to-charge ratio to allocate hospital Medicare dish payments when that cost-to-charge ratio may include provider types that are not hospital facility services. I think the short answer to that is because it's very simple for them just to pull an overall cost to charge ratio and not have to go back and try to sort of carve out those other entities that have separate payment systems themselves. So I don't know if it's just for simplicity's sake that they've decided to do that. That is one concern that the provider community has, is that it may not give you the most accurate computation of uncompensated cost by doing so. So again, that's hopefully one of the areas that CMS will clarify and possibly look at revising. But again, I think if they start carving out those other entities, it's going to involve a lot more effort on their part, and I don't know that CMS wants to do that.
And for those of y'all that are filing state disproportionate share hospital survey information, at least I can speak to those states within the Southeast. A lot of them are becoming more uniform as it relates, and really they're more detailed. The only disconnect is they're not considering the same exact information in coming up with an uncompensated care cost determination. But a lot of those state surveys that we've seen, or the processes that have been put in place as it relates to those surveys, are actually calculating using the Medicare cost report inpatient per diems and the cost center cost to charge ratios applied to charges by cost center and days times the per diem, which that's a more specific, but it's also a more labor-intensive effort.
Thanks, guys. I guess I'll close with this question. What can we do currently to prepare for when CMS does decide to start using the S-10 for Medicare uncompensated care payment allocations?
Well, I think that's a two-front answer here. The first one is, as long as we continue to use the empirical DISH methodology, is we need to ensure we are identifying and claiming as many Medicaid eligible patient days as possible. Because, again, as long as they continue using the old methodology to do the allocations, we need to continue our efforts in that front. Secondly, as far as the S-10 worksheet goes, you need to have a proper understanding of what you're required to report on it, document your input amounts, and maintain that detailed support. Review your charity care policies to see if they need to be revised in any manner, because again, the more patient accounts that you can determine qualify for charity care, that will only help your uncompensated care pool allocations once they switch to using the S-10 data.
And as it relates to your, the evaluation of your charity care policy, it's going to take some data analysis as it relates to your historical payment or collections from the uninsured and charity population. And really, at that point, you can make a determination, does it make sense for us to revise our charity care policy to capture